Great. Good morning, good afternoon. Glad to see people trickling into the session today. Kindly give us a couple of minutes to let colleagues join, and we will be kicking things off shortly. Thanks. Great. So I'd like to welcome everybody today to a special webinar hosted by USAID, Path Digital Square, UNICEF, and the DICE Consortium. We're going to be diving into some of the lessons and best practices that came from the COVID-19 response and talking about a primer that we developed and launched, and where we see this primer contributing to the transition and post-pandemic preparedness. With that, let's jump into the session. Next slide, please. So I'm very excited to welcome three colleagues who are experts in their field. Introducing myself first, I'm going to be your moderator today. My name is Sean Blaschke. I'm a senior health specialist with UNICEF's Digital Health and Information System unit. Joining us, we have Dr. Pramod Amarakun. He's the lead and senior information system implementer from HISP Sri Lanka. We have Sean Bolton, who is the ICT lead in Jamaica at the Ministry of Health and Wellness. And Amrit, Digital Health Advisor for USAID. Next slide. Fabulous. And so in terms of run of show, this is the introduction. I'm going to be handing it over to Amrit, who's going to be providing, again, some background on the primer itself, the thinking behind it, why we did what we did. We'll be turning it over to hear and get key insights from country colleagues from, again, Sri Lanka and Jamaica. And then hopefully we will have sufficient time for my favorite part of these webinars, the Q&A. So queue up your questions and throw us some good curveballs. Next slide, please. So giving some background and taking us back about 3 years, the COVAX Innovations Working Group, who was looking at different digital health and health information system investments, identified essentially what were 7-8 different priority areas where we felt digitization and digital health platforms could contribute more immediately to the COVID-19 response and be transitioned to long-term routine immunization and health system investments. And so we had worked to identify and recommend both how to take existing WHO guidelines, as well as identify and select the most appropriate interventions for countries to consider. Again, we tried to be very much technology agnostic, but rather driven by country NDVPs, by their health strategies, and the requirements coming out of government programs and ensuring that the right solutions were matched up to what they needed at the time and could be transitioned to what they needed over the long term. Next slide. So you're going to be hearing a little bit about digital public goods and global goods. And one of the considerations as UNICEF, as the DICE consortium, as partners, is that we wanted to ensure that governments really looked at IP, intellectual property, and ensuring that the solutions that they had selected, identified, and implemented were systems that they really could truly own. I would note that while the primer focuses on digital public goods, open source platforms, we're very pragmatic with our approaches, and in some cases, proprietary solutions, other models may make more sense. But again, I think what we wanted to do, at least with the primer, was focus on those tools that really were not linked to a specific company's commercial enterprise and didn't create issues with vendor lock, in which at the time, particularly when governments needed to move fast, we wanted to ensure that the solutions that they were considering met some of these principles behind digital public goods and global goods. Next slide. And so finally, before I transition, I wanted to set the scene in terms of where we were back in 2020 and what considerations led to the way the primer was framed. First and foremost, we saw this as a unique once-in-a-lifetime opportunity or once-in-a-generation opportunity to really leverage a lot of the investments going in to ensure that stronger, more resilient health systems resulted from these investments during the COVID-19 pandemic. And to do so, many of us who had worked on prior health emergencies like Ebola and more regional or country-specific health challenges, public health challenges, have recognized and dealt with issues caused by poor coordination, overlapping tools, and one of the things that the primer really wanted to focus on is ensuring that we are investing in existing systems. None of the interventions that came in during COVID-19 happened in a vacuum or a greenfield. Governments were already investing in often large-scale enterprise programs, and we really wanted to make sure that any COVID-19 investments took that into consideration. We also recognized the challenges of vertical, unscalable, or unsustainable solutions, interventions that really didn't take into consideration the digital maturity of the country, the capacity of the existing systems and people, and the finances and infrastructure required to manage, maintain, and continue these investments. And we also really wanted to ensure that as solutions were being identified, we were taking into account many of the emerging standards, reference architecture, requirements, and guidelines that were coming out of the global community to, again, ensure that best practices were being followed and that the solutions that were being implemented were robust and aligned with clinical guidelines, best practices, and could eventually fit into either immediately or eventually into the national health system. So with that, I'm going to hand it over to Amaranth, who will talk a bit more about the primer itself, why it was developed, and where we intend to go with it. Over.
Great. Thank you so much for that framing, Sean. So as Sean said, I'm going to provide a little bit of information about the resource that we are officially launching today, the primer on digital solutions for COVID-19 vaccination service delivery, as it's going to help to frame the rest of what we're going to hear and talk about today. And I'll also go ahead and drop a link in the chat to the primer's mini site, so you have it on hand to check it out later. Sorry. I'm hopeful that the challenges and the opportunities that we hear about today from our panelists can also provide some real world grounding for the recommendations in the primer, and that we're able to use these learnings as we look forward to integrating COVID systems into routine and primary health systems and to preparing for future health shocks. So you can go to the next slide. Originally, about a year ago, actually, we developed the material for the primer just as a simple slide deck to serve as an internal resource when global attention was focused on getting vaccines from ports into arms in low and middle income countries. We designed the primer to address needs that we saw arising from the COVID-19 response, but our hope is that the primer can continue to be useful across really two main domains. First, in the realm of immunization, and then second, for future pandemic responses. So next slide, please. In the realm of immunizations, the primer adapts a framework that was originally developed by the World Bank to map and then organize the many different ways that digital tools can support throughout the entirety of the immunization service delivery process. So you can see here, this is the framework with each box representing a different use case for digital solutions. In the primer, we go into detail about what these use cases involve and even provide mini case studies and toolings lists to make the ideas concrete. And I really recommend you take a click through. The PDF is full of jump links so you can navigate easily and don't need to read through the whole thing like a book and just go straight to the parts that interest you. Next slide, please. In the realm of pandemic preparedness and response, the primer advocates for an adapt and scale approach, which is what Sean was alluding to. By adapt and scale, what I mean is taking an existing digital solution and adapting it to a health emergency use case. So an example of this could be adding the COVID vaccine to an electronic immunization registry. And then the scale part of adapt and scale refers to ensuring that the solution is deployed at scale to reach the populations in need. And this approach has the potential to support both deployment speed, which is critical in an emergency situation, and then also digital system sustainability. So on the speed side, you don't have to start from scratch. And then on the sustainability side, you would be building off of existing systems that may already be integrated into the health system and have use cases and support and funding that would see them through to the other side of the pandemic response. And this could even have a health system strengthening effect by shoring up existing solutions. All that being said, applying the adapt and scale approach can be really challenging when there isn't a clear picture of the existing digital health landscape, for example. If you don't know that there's already an existing electronic immunization registry, going back to my earlier example, you wouldn't know that you might be able to adapt it, which is a great reason to invest in early in landscape analyses and maturity assessments. There are really a host of additional challenges involved with adapting and scaling, as many folks in the audience are probably aware. Most EIRs are not designed to deal with adult populations, just with children. And there are tons of factors that came into play as countries thought about how to leverage digital solutions to support their COVID responses. And at this juncture, one of the most important questions relates to what happens now with COVID systems. How are these systems being adapted or even sunset to support health systems in general? And this is where I'm pleased to turn it over to our panelists to dive into some of those practicalities and really help us understand what's shaping country decisions, what shaped country decision-making processes, and how they're thinking about current challenges and opportunities related to digital systems for COVID-19 vaccination service delivery and beyond. Thank you. And with that, I think I'll turn it over to Sean Bolton, if you're on.
Hi, good morning. Are you able to hear me?
Yes.
Okay, great. So for the Jamaica context, in terms of COVID and dealing with COVID, COVID impacted our socioeconomic situations in Jamaica, where we were severely impacted at that time. So what the government did is to approve a vaccine deployment and vaccination interim plan, which was led by the the vaccine management task force. So this task force, we developed teams and substreams or work streams from this team to ensure a successful rollout during that time. These teams comprised of clinical management, human resources, logistics, information systems, communication and supply, and cold chain management. So what contributed to our success during the COVID is that we tried to build partnerships from our private partners, international donors, partnership with our regions, because in Jamaica we have 4 regions and 4 autonomous regions where they do their own business operations. So we had to build those relationships with those people. So in terms of how do we go forward and in terms of a future state, is that we have to try to learn from some of the lessons during the COVID pandemic, developing strong communications between facilities and vaccination centers. We have to ensure that we have political and senior leadership approvals and buy-ins, as well as rolling out change management procedures to, advise and make the public aware of what is happening and the need for this digital transformation. Going into the future, for routine immunization, we have learned from the COVID pandemic and dealing with the COVID-19 response using digital health, is that we have to build stronger infrastructures. So as part of the ministry's plan is to develop and improve on infrastructure and communication between facilities to ensure fast delivery of service to its residents as it relates to documenting of vaccine information. So one of the plans is primarily to have the government itself adapt to the changing environment, moving from a manual process to a digital process. So that is one of the first things that we have to do to ensure, adaptation for this. So what we have established is change management protocols. So as part of what we're doing is to, we have already hired a change management specialist to make not just the clinical technocrats aware of the need for digital health, but as well as the residents and citizens, I must say, of Jamaica. So what we have started with, what we plan to start with is 0 to 6, which is what we have started 0 to 6. Then the intention is to move on to adolescents and then to adults. So we want to take a life course approach with the vaccination, immunization, routine immunization. We want to take that life course approach to move forward. So one of the things that we have looked at is, and our minister said it, is that we need to introduce partnership with the implementation of these digital health solutions, and partnership is good. And if there was a lesson learned from COVID, is that healthcare has to change. We cannot do things the traditional way. Improving on digital platforms today is a real paradigm shift in Jamaica. And we have realized that with the COVID pandemic, and this is a momentous occasion where Jamaica will learn from the COVID pandemic and move on to more routine immunization. This will improve patient care. This will improve on timeliness, analysis, and pretty much improve on medical delivery in Jamaica. over. Thank you.
Fabulous, Sean. I'm going to take the liberty and ask a couple of questions right now, given that I know you are double, triple booked and may have to leave early. So Sean, you spoke a bit about infrastructure specifically being a challenge for Jamaica. In terms of what factors you looked at in determining what were the right approaches, what were the right solutions, how did things like infrastructure guide what was possible given the context you had, and what might not be appropriate?
So I had to look on, a digital transformation on a whole. First, not just the solution, because a solution cannot work without communication, connectivity, the required devices. So we had to implement that transformation. And this is what we have learned through COVID, because when COVID started, we were unable to communicate effectively between facilities for reports, analysis, and decision-making. So the ministry initially started to improve on 13 facilities. But because of COVID and we saw the need for emergency responses, we had to increase that number to 105 facilities. So we have over 350 facilities within Jamaica, but we have started with 105, planning to scale up thereafter. Then we have to look on the solution. What solution can we put forward to improve on the digital collection of information? How will this solution affect the users? How this solution will affect the citizens? So we also have to look on the infrastructure again, or ISPs. We in some of our areas there are low connectivity, so we had to look at a solution that would adapt to any environment, right? We tried to also have a centralized solution, thereby ensure that data is at the fingertips of all the users of the system. So these are some of the factors that we had to take into consideration.
Fabulous. Noting the again, going back to your comments around change management, the life force approach to routine immunization, and the identification of appropriate technologies and platforms. I would love to hear a bit more around what considerations you made when you selected, in Jamaica, ComCare and DVOC as tools. These are digital public goods, but they come with the need for a coherent approach and strategy to supporting these tools. What was your thinking behind the identification of these platforms? And looking back on the process, is there anything that you would have done differently?
So in terms of getting a solution to manage the COVID-19 pandemic, we had a requirements document that had to be swiftly developed. So we had a few requirements outlined. We did what we call emergency procurement for a solution. So we looked at, during that time, I think it was 4 solutions we had to look on during that time to ensure that these solutions met the criteria. That is for the COVID data collection. So that is how ComCare get involved. We as I mentioned before, we wanted a solution that is that was readily available, open source, a solution that can be transferred to the ministry for our future move, to ensure that it is sustainable. We didn't want to go with a proprietary solution, which will impact our costs. We also had to look on a solution that could work offline, and that is mobile. We also had to look on security of data to ensure, that it meets, health standards, HL75 standards. So these are some of the that we had to look on for ComCare. With DIVOC, the plan is to have the citizens have access to their data. So we needed a digital solution, a secure digital solution that would provide this to the citizens of Jamaica as well, and for internal and external use case. So ensuring that we had a QR code, a secure QR code that will not be is basically impossible to replicate and to alter. So we had a partnership with e-government of India, where they provided us with an open source solution as well. We also had to look on the sustainability of this as one of our primary criteria as well. So in terms of going forward, the aim is to migrate all these solutions to our local servers to ensure that we can manage it, build capacity within Jamaica to manage these type of solutions, as well as, and as I mentioned before, reduce costs. What we have learned, and what we would have done differently, it's very hard to say because the pandemic came upon us. I don't know. It came upon us, right? There were pretty much no warnings for COVID, and we had to deal with it. So the manual-based system that we had, paper-based system, it was very difficult for transition of information between parishes, between health centers. So, we would have persons from one end of the country getting vaccinated there and getting a different vaccination at the other end of the country, or perhaps more than they should, because there's no information that is readily available to the healthcare workers. So, as I mentioned before, it would have been pretty difficult to look at what we would have done differently. What we would have wanted to do differently is to have an emergency response to deal with solutions, to deal with situations like these. So what we have done now is to have our emergency plan, build out the infrastructure. So pretty much we are trying to get ourselves ready in the event of another pandemic. So the solution that we have would have to deal with other events coming up. So if there's another pandemic, whatever it is coming up, then the solution ComCare would be easily amended to adapt to whatever event came up.
Fabulous. Sean, I just want to express my appreciation again to the tremendous and inspiring work that came out of Jamaica, as well as taking the time today. And just to reiterate, I think your last comments around lessons learned are something that everybody should take home. I think one of the things we struggled with in terms of responding to COVID was that we had to do everything all at once. And a lot of this was due to the fact that we hadn't invested in strong, resilient systems years in advance. And so, as a takeaway in terms of what we can do better, this is something I think collectively as a digital health community, we want to come out of this pandemic reinvigorated and ready and willing to strengthen these national systems so that hopefully there won't be a next time around, but if there is, the heavy lifting to get systems in place will be minimal, or the systems will already be ready to be deployed. So again, thank you, Sean, for joining today. With that, let me hand it over to Pramod to talk about the experience in Sri Lanka. Over.
Thank you.
Hello everyone, I'm Pramod from HISP Sri Lanka. Let me start sharing my screen. Right. So today what I'm planning to present is the lessons learned from the digital response for COVID-19 vaccination in Sri Lanka. So Sri Lanka is one of these countries which was an early adopter of open source solutions for the digital response for COVID-19. So what you are seeing here is a timeline of first few months of year 2020. So we all remember, like we came to know there is something called COVID-19, or it was back then not even called COVID-19, that emerged all of a sudden in December 2019. And as you can see here, in third week of January in year 2020, the Ministry of Health Sri Lanka had some discussions, some internal discussions on deciding like what should be our digital response for COVID-19, and what's the platform, what's the technology that it's going to use to collect this data and to disseminate it. So based on so many reasons, which I'll be talking about a bit later, they decided to opt for DHIS2 platform as the base for collecting all this COVID-19 related information. So what you are seeing here in the remaining of this timeline is that like within a duration of 4 months period, they were able to develop several modules or components on the DHIS2 platform to collect different types of data required for the changing information required based on the epidemiology of the disease. So let us now look at like what happened towards the latter part of the year 2020 in Sri Lanka. So the thing was, now towards the latter part, the information requirements were kind of stabilizing. So we were thinking like, okay, now we kind of covered everything. But around October, November, that was the time that the WHO country office, together with the Ministry of Health, started discussing like, okay, we are getting these vaccines for COVID-19 probably in 2021, early 2021. So we need to be prepared on how to collect this information, right? So that was when we discussed, we as in like the HISP as a partner and the WHO and the Ministry of Health Sri Lanka, together with so many other different stakeholders in the government, discussed like we need to kind of adopt all the, we need to cover all the information requirements around the vaccination, and then also need to accommodate this in the existing platform, or we'll have to build components on top of it. So what you are seeing here are the different components which I mentioned before, which was developed on DHIS2 platform for the requirements around COVID-19 surveillance in first couple of months of year 2020. And they designed some components on DHIS2 plus using other digital public goods to address the information requirements around
to support it.
vaccination.
Many times we don't have enough servers. We've heard this problem from IT over and over.
Right. Okay. Yeah. I hope I can proceed. Right. So talking about the COVID vaccination and the related information requirements. So the government identified, the ministry identified several components that they need to develop. So the first thing was to kind of track and register all individual vaccination requirements. These are individual vaccinations. And then, of course, to keep track of all the stock of vaccinations, and then required to produce the digital vaccination certificates for so many reasons, and also kind of provide some means for the citizens to request and obtain that vaccination certificate. So what you're seeing here is a sample of the COVID-19 vaccination certificate that we are using in Sri Lanka. So we decided to build most of the components on top of DHIS2 platform. So what you're seeing here is the aggregate data collection form for the stock monitoring, which we initially created in late 2020. And then, of course, the individual vaccination data collection component, again, on top of DHIS2. So this was used for capturing the individual vaccination information, adverse events following immunization, as well as they also wanted to monitor a cohort of pregnant female who received the vaccination. So these were the components that was covered in the tracker component of the DHIS2. And in addition, there were some analysis and data use requirements for which the platform had to cater. So there were like a couple of analytic tools in DHIS2 using which the government was able to produce these dashboards. And for other requirements, the platform had provisions to export data as Excel and also to run some SQL queries against the platform to get some additional analytics. And the implementation, let me talk a bit about the process and the technology involved. So the initial implementation happened in early January 2021. Together, I mean, it was like around the same time we received the first stock of vaccination. So before doing that, we pre-registered the entire population. Luckily, we had a voters list as well as a national ID in Sri Lanka. So using that, we were able to pre-populate or pre-register the entire population, and then we accommodated almost all requirements inside DHIS2 platform, even to produce a basic certificate. But the problem was that like there was some it was not a problem, actually the complication was that there were some recommendations and guidelines to which we had to adhere to. So the initial version of the certificate we produced was just a basic one which can be validated by logging into our online portal. But with this WHO guidelines, as well as like there were like few others which came afterwards, we had to kind of adopt a cryptographically verifiable vaccination certificate. And for that, we used this platform, a digital public good called DVOC, which was again mentioned by my colleague from Jamaica. So we used that and we created an integration between DHIS2 and DVOC to produce this vaccination certificate. And on top of that, we also created another platform or a portal for the citizens to request their certificates. Right. What you're seeing here is based on a study the research group we conducted at the University of Oslo together with the Ministry of Health Sri Lanka, which was presented mid last year at DHIS2 annual conference. So we are looking at the completeness and timeliness of data entry of individual records. So we are talking about a population-wide vaccination campaign where we are thinking of registering everyone and also capturing all the vaccination events. It was not just one dose, there were like a couple of doses. So the good thing was that in Sri Lanka, like we were able to achieve 87% completeness, overall completeness. And when we look at the timeliness, you will see like about 40% of these vaccination events were entered in the same day or like within a period of 2 days. So it's kind of like near real-time data entry. And if you look at the number of vaccination events that were captured during the first 2 weeks, it was roughly around 66%. It's about 2/3 of all the vaccination events. So this was made possible not because of we followed the same regular process that we are doing for the routine immunization, but we had a lot of help from all the government stakeholders, including the military. So the government kind of deployed the military to support in vaccination campaigns at the vaccination centers, and they were even helping in entering the data. So it was a lot of effort that was put in place for us to achieve this completeness. Right, so let us now briefly look at some broad areas of lessons learned. Let me emphasize by saying it is not about the technology, it's mostly about the people. So I believe like managing the people factor is most crucial when it comes to technology implementation, and it's not just the platform or the type of technology or the programming language that really matters. So the first pillar that we identify is the high-level governance and the multi-sector collaboration. So there was a commitment from the high level of the government, including the president himself, and he assigned a presidential task force to look at the COVID data management and vaccination. And then there were like a lot of partners involved. It was Ministry of Health leading, but there were like few other ministries as well as development partners like WHO country office, who was really engaged from the beginning in providing technical assistance. And then we also had the government ICT agency, who's kind of like a central entity who's providing all ICT services to most of the ministries in the country, who took a major role in supporting these implementations. And we also had the private sector who's contributing, like what the image that you're seeing here is a hackathon that we conducted during the pandemic to create components, to build components on top of DHIS2, and everyone who participated were from the private sector, the volunteers who kind of contributed. And also we had a lot of support from the people outside of the country, especially the HISP network. We are a kind of a small network, relatively large network when you actually consider the number of countries that we support. So we were in constant touch and communication together with the University of Oslo in building this component. So it was a kind of a multi-sector collaboration that really worked well during the pandemic, that really contributed us in coming up with all these solutions. And in addition, the digital platforms that we used. So the thing is, we as in Sri Lanka has a long history of implementing DHIS2, meaning like we had some capacity at the core level of the ministry at national and even at subnational level. And the ministry itself was competent in customizing the platform to kind of suit the COVID-19 related requirements, because we didn't have fortunately, I would say, like we didn't have to face any major pandemics before COVID. So we didn't really use a digital system before, or even DHIS2 for that surveillance purposes before. But the country was able to come up with all these solutions, mostly with the local resources, because they had the capacity, and of course because of the platform that was used. So DHIS2 in particular was a flexible, customizable platform. So we were able to adapt most of the requirements. But then again, like we knew the limits. So for example, to produce this cryptographically verifiable certificate, we were aware like of DEVOC platform, which was used in India with a major success. So we had a nice collaboration, and we built components, integration components, which enabled DEVOC to talk to DHIS2, and finally we were able to produce this certificate. And not only that, all these components that were developed within the country was shared with the community. Some of you may be aware that the initial versions of the surveillance package as well as the COVID immunization packages that were developed in Sri Lanka was shared with the global DHIS2 or the HISP community, which really helped them in designing the DHIS2 metadata packages, which of course is used by more than 40 countries at the moment. And finally, the last pillar I want to highlight is the enabling local capacity. So the building that you are seeing here is a building from the University of Colombo in Sri Lanka. So in year 2009, Sri Lanka government identified that we need to build local capacity in digital health. So what they actually decided was to train medical doctors and initiate a master's program, again from initially with a grant from the Norwegian government and with some support from the University of Oslo. They established a master's program, and even after the funding stopped, the University of Colombo continued with this master's program, and now even we have a doctoral program. What it does is to train the medical doctors who are already in the Ministry of Health on digital health, and once they are trained, they are absorbed back into the Ministry of Health and placed at district as well as national level. And the main task that they are doing is to build capacity across all different categories of health staff, as well as to support the implementation of digital technologies and the guidelines. So they were of real help in implementing all these different digital solutions during the time of pandemic, when resources were constrained and there was like minimal mobility. So I believe this local capacity as a third pillar that is behind the success of the vaccination program. So I will just stop there, and probably we can take a few questions. So thank you very much.
Thank you very much, Pramod. And again, I think many of us looked at Sri Lanka with a bit of envy in terms of how quickly you were able to build off of years of previous investments and really deliver solid results at scale. So as we open it up to the Q&A, I'm going to invite colleagues either to raise their hand and ask a question directly, assuming that is allowed with the Zoom meeting chat. Additionally, feel free to put your questions directly in the meeting chat, and I will read them. But to kick things off, as colleagues are putting their questions together, I'd like to touch quickly on the last slide around enabling local capacity. And Pramod, we've discussed this previously. In terms of what are the types of questions, what are the types of considerations a government or a partner like HISP will look at when they are selecting, identifying solutions. While looking at a single solution is often easy, what we see is that governments often are putting together a suite of different solutions covering LMIS, HMIS, HRH. And so, in terms of what do you look at in ensuring that government is approaching this systematically and that you're matching the right capacity to the government's needs? So if you wouldn't mind giving us a little bit of insight into kind of how you approach questions like this.
Yeah, a very good question. So let's be honest, like personally myself, like I have been using DHIS2 for a very long time. So for me, like initial tendency is to check like whether it's a fit for DHIS2. But having said that, generally the approach of HISP is like we really work closely with the governments. So what we do is like what is best for the governments. So with that, like even if you look at the challenges that we had in Sri Lanka was like let's focus on COVID-19 vaccination. So the thing is like when it comes to Sri Lanka, like if you look at all these three pillars, they were there. So Sri Lanka had especially like when it comes to customizing a platform, it could be whatever the platform, they had some core capacity within the Ministry of Health, and especially they had a government ICT agency which itself has a lot of capacity, and they are also providing infrastructure like hosting and a kind of a internal government network which kind of connect all the different the health institutes. So in a setup like this, we are kind of more we might even say adventurous. Like for example, we tried implementing DHIS2, and on top of that, like whenever DHIS2 core applications were not a good fit, we tried to build components on that, like web applications, and kind of we really exploited the potential of the API. And even the specific example of TVOC, why we used TVOC was that like we had a kind of a meeting where like Ministry of Health, WHO, the ICT agency, as well as University of Oslo was there in that meeting. Like they never pushed the country to adopt DHIS2 because they are already using DHIS2. They identified the potential of the country, and they themselves kind of recommended, okay, if you have this much of potential, like the capacity, the infrastructure within the country, then of course you can adopt a platform like DIVOC. Like so, the thing is like when you look at DIVOC platform, it's a very robust platform and which could really scale because it was working in Sri Lanka, in India. So when we were trying to fit it into the country, we kind of focused on building capacity especially in the ICT agency, because HISP, like we were really overburdened supporting the DHIS2 and all the modules. So we didn't try to take that. So it was the ICT agency was there to take that forward, but we were working mostly on building the integration components. So likewise, the thing is like it's very contextual, I must say. So you have to have some understanding of the local capacity, infrastructure, the governance mechanisms in the country, and see like what really can work. So for a country which doesn't have all this capacity and the infrastructure, some of the DPGs, even though they are really good technologies, they might not work. So it's very contextual, and I think a proper understanding of the context of the country is really important before you try to implement a digital technology, because it otherwise it's going to fail, and it's not going to fail because of anything wrong with the technology. It was mainly because we kind of applied something which is not a good fit.
Fabulous. A lot of great insights there. With a similar question we asked Sean earlier, when you looked at the enabling environment in Sri Lanka and looking forward, what are the areas that you think are most critical to invest in to strengthen for solutions like this to work? Pulling from one of the questions in the chat, can you talk a little bit about HRH, human resource capacity, and where you see the role of community health workers fitting in, and what kind of skills did you focus on during the COVID-19 response, and where there may be additional areas to strengthen moving forward?
Yeah, so let's be honest again. So all these three pillars that we highlighted, we kind of from a academic research perspective, I would like to call it as a agile governance, right? A governance that was really agile, that was working really well in Sri Lanka during the pandemic. But the thing is, like, we were able to get all these things work because like there were like few enabling components. For example, the local capacity, which was already there, and the platform again, like we have been using it, and the all the health staff was familiar, and then we have these government institutes who supporting. Like it was all there, and we also had a very high level governance policies. For example, we had a health information policy. But the thing is, like, supposing if all of these didn't kind of come together in an agile manner, things wouldn't have really worked during the pandemic. So this agile governance was working, but like we didn't really have proper in detail policies on how these foundational elements should be implemented. So it was kind of we were kind of fortunate in a way that the things really worked. But I think the government and the Ministry of Health specifically has realized this, and just after the pandemic, they have been really working on developing a digital health blueprint, and they have published it, and now they are kind of working on implementing the digital health blueprint and to kind of align all the different technologies which are already there and the processes the country is already having to align with this the blueprint or the governance. So I believe like that is required. Even though, like, say for example, if we are going to face the next pandemic with the existing enabling environment and without having a proper governance, we are not really sure that everything will work the same way, because there were like a lot of moving parts and everything was more agile. So I believe like it's a kind of time to now make things more solid and have them all properly written down and implemented so that we can be better prepared for the next pandemic if it comes.
Great. So I'm looking at the chat and the participants. I see that we have many people who are working on different digital health apps and platforms and tools. And going to your experience in Sri Lanka, both working with the Ministry of Health as well as wearing your HISP hat, do you have specific recommendations, reflections, thoughts on how a private sector, a public sector partner with a tool that they're really passionate about, how they can engage with both governments as well as partners like yourself within these frameworks of the governance and coordination structures being established in many countries and the blueprints which are increasingly providing that roadmap. So again, in terms of how new entrants to a country, what is your advice on how they can work with partners like HISP as well as open doors and engage with ministries?
Yeah, so I believe the first thing that you have to do is like you really need to understand what is there in the country, like or otherwise what will happen. Say for example, we realize that there is something, a particular use case where the tool that you are having will be a good fit. But if you already have a kind of another platform which is kind of matured and may not be even the ideal fit, but if it is working in the country, and if you are probably trying to implement your tool into that well-established use case, it might not really work, mainly because like you might be kind of creating a lot of frictions engaging with the government and all the partners. So probably you need to kind of do a proper situational analysis and to understand like what are the different tools in the country, what's the level of capacity, what's the different use cases, and what's the kind of governance mechanism when it comes to the information sharing and information workflows, and probably identify a good area where your tool is a fit. And the next thing is like you can kind of pump in a lot of resources through partners, donors to kind of get a pilot success. But for a tool to be really rooted in a country, you need local capacity, because the moment your resources and the funding stops, if the ministry does not own the platform, you won't really be able to kind of take it forward. So either you need to have some presence, or maybe work with the ministry in building co-capacity, or work with the partners who are already there, and work with the ministry program, and probably even conduct advocacy. I think in most of the countries, the high-level stakeholders or the officials do not really have the insight and probably the understanding, and don't really realize the value of the capacity in sustaining digital technologies. Like sometimes like They just go by fancy interfaces or like, vivid descriptions that you get out of the raw data, but it is never going to kind of sustain a platform. So you either have to work with the partners, or somehow you have to build capacity within the ministry so that even after like a couple of years, you can sustain the platform. And also do a lot of networking, find regional partners. Like if you are really one organization who is located really far away, you really need to engage with the network who's close to the country so that they can in turn help in building capacity and contribute. So it's like always about collaborations and building capacity, which is kind of the key. Like again, it's about the people and not about the technology.
I love that you're going back to the people, the systems, the processes, and highlighting that the technology is never this, not even a silver bullet, but even a rubber bullet here. Very true. Resonates strongly. I have one last question, and I'll keep monitoring the chat to see if anything else comes in. But in terms of some of the recent move towards standards, we had some people talking about interoperability. There's been a lot of buzz around FHIR as of late. How is the HISP team in Sri Lanka? How is the Ministry of Health looking at this, ensuring that we use standards appropriately, but we don't become blinded and throw out a lot of good solutions that maybe aren't standards compliant. Kind of what are the things that you as HISP weigh when looking at, is the time right to introduce or to adopt a standard? What are the considerations that you take, and what are the benefits, risks that you see as being a early-ish potential adopter? Over.
Yeah, so I will try to explain from both the viewpoints from Sri Lanka as well as the HISP. So from Sri Lanka's perspective, as I mentioned before, like learning from the pandemic, now they have come up with the digital health blueprint, and they have identified FHIR as a main standard that should be respected in the blueprint. So there's a lot of work underway to identify solutions, mostly open source, that can work with FHIR, as well as to understand the existing stock of knowledge and the implementations which are in the country, to explore how well the data can be shared and all the solutions can be interoperable. Again, like there are no great examples if you look around in low and middle income countries, and even in like the developed countries, where you really have a country where like you have streamless sharing of health data, which is rare, right? So the thing is, like, it again is a learning exercise. So the ministry is very careful in trying to implement. So they are experimenting with few solutions and trying to adhere to the standards. Again, like while accepting the fact that we have to adhere to the standards, they don't want to kind of kill or get rid of all the implementations and the efforts that have been put in place in the country. So there are few implementations which have been tried out, including there are some implementations around OpenSRP, if I mention one, DPG. So like we are exploring all these different solutions, again, like from a country perspective. From a HISP, again, like we are open to all these different technologies. And the thing is, again, like even from the UIO standpoint, the thing is like to explore integrations. And one major challenge that probably not most of the donors don't realize is, like, once you create integration, it requires a lot of resources to sustain it at a central or like at a global level, as well as like at country level. So you have to be really careful in identifying the integration requirements and the process you do it. So from a HISP perspective, we are kind of looking at some solid use cases and commitments from countries in exploring this integration. So we did it in Sri Lanka, DVOC and DHIS2, and we are also exploring some MOSIP DHIS2 implementations. There are a few countries, for example, like Rwanda, who has expressed willingness to do this. And again, like we have few countries where, like for example, Rapid Draw it's been tried out, the integrations with DHIS2, and there are many other. So like as I mentioned before, the commitment has to be there from the country and government, and there has to be proper use case, and it has to be well planned the entire integration, because it is going to cost a lot of resources.
Fabulous. I'm gonna close down the session with those questions. All things that I think we need to look at in terms of both identification of solutions and how we adapt, we take on, we support standards. So with that, I want to provide a huge thanks to our organizers today, from Path and Digital Square, to our panelists, USAID, and representatives from HISP Sri Lanka, and the Ministry of Health in Jamaica. So again, I hope people were able to take away, if not answers, pertinent questions that will help you all in terms of identifying and planning digital health programs in your respective countries. And again, appreciate the time taken from all of our participants in the audience today. So with that, thank you, and we will see everybody during the next webinar. Thanks.